Disorders of esophagus in children. Esophageal atresia. Discontinuity in the esophagus is called esophageal atresia. Associated anomalies. Tracheoesophageal fistula (TEF). Most common defect in the mesenchymal separation between trachea and esophagus. Gross classification, you have type A, B, C, D, E, F. Type A is isolated esophageal atresia. Trachea is present, esophageal is just a blind pouch. There's no connection. Type B is esophagus is opening into the distal esophagus. Trachea. Proximal TEF. Type B is proximal TEF with distal EA. Type C is proximal esophageal atresia with distal tracheoesophageal fistula. Which is the most common? What is the most common type? Type C is seen in 85% cases. Type D is proximal and with distal tracheoesophageal fistula. Type E or H, tracheoesophageal fistula without esophageal atresia. Type F, esophageal stenosis. This is the classification. Vectoral association. What is vectoral? V is for vertebral anomalies, imperforate and anus, cardiac defects, tracheoesophageal fistula, renal anomalies, and limb anomalies. Clinical features: vomiting, multiple episodes, aspiration pneumonitis, excessive frothy salivation, antenatal polyhydramnios, inability to swallow amniotic fluid, so there is polyamnios. So there is vomiting, multiple episodes, aspiration pneumonitis, excessive frothy salivation, antenatal polyhydramnios, inability to swallow amniotic fluid. Investigation: chest x-ray, resistance encountered during insertion of nasogastric tube, coiled nasogastric tube in proximal esophagus in the x-ray. Treatment: anastomosis of esophageal end and division and ligation of tracheoesophageal fistula. Gastroesophageal reflux disorder (GERD). Clinical features: less than 6 months infancy, recurrent vomiting due to short esophagus, like aspiration, malnutrition, failure to thrive. Sandifer syndrome characteristic: spasmodic dystonia, posturing of the back muscles, opisthotonus. Sandifer syndrome. Note: opisthotonus is also seen in neonatal tetanus, bilirubin-induced neurological damage, which is bind. So you have your opisthotonus in Sandifer syndrome, neonatal tetanus, and bilirubin-induced neurological damage, bind. Investigation: 24-hour pH monitoring of esophagus. pH less than equal to 4 indicates GERD. pH M2, multi-channel intraluminal impedance monitoring. What is pH M2? Multi-channel intraluminal impedance. It is MII, multi-channel intraluminal impedance monitoring. Bed test measures the level up to which reflux occurs. Upper GI endoscopy: erosions and breaks in esophageal mucosa seen. Erosions and breaks in esophageal mucosa is seen. pH indicators: esophagus and stomach. Diet and lifestyle modification. Modification: small, frequent feeds, thickening of feeds, avoid caffeine, spicy food, avoid chocolates in older children. If there is no improvement, then pharmacological, like proton pump inhibitors like omeprazole and lansoprazole. What proton pump inhibitors do you give in children? Omeprazole and lansoprazole. Duration is 3 months to avoid recurrence. The duration is 3 months to avoid recurrence. If there is no improvement, then you go for surgery. Done for refractory GERD, you do Nissen fundoplication. Nissen fundoplication, part of fundus wrapped around lower part of esophagus. Increased lower esophageal sphincter, LES tone and pressure, decrease reflux. Foreign body in esophagus. Features: age less than equal to 3 years. Common foreign bodies: coins, nuts, small toys. More than one magnets are shown in the image. Dangerous foreign bodies: button batteries. Coagulative necrosis of esophagus. Multiple magnets stick to each other across bowel loops, obstruction, perforation. Sharp objects. Natural course: most of the foreign bodies, more than 95%, will pass through and get excreted. Site of impaction: they can get impacted on cricopharynx, mid esophagus at level of tracheal bifurcation, right above lower esophageal sphincter. Clinical feature: history of ingestion of foreign body may be absent, may be asymptomatic. If symptomatic, drooping of saliva, refusal of feeds, chest discomfort, pointing towards discomfort, respiratory complaints, recurrent cough, wheeze due to pressure effect on trachea. Investigations: X-ray. Only radio-opaque foreign bodies can be visualized on X-ray. Contrast study of esophagus or esophagogram. Filling defect is seen. Management: conservative. Blunt object and asymptomatic. Observe for 24 hours. Indication for removal by esophagoscopy. Symptomatic. Impacted for more than 24 hours. Batteries, magnets, and sharp object. In next video, we'll see diarrheal disorders in children.